Hello friends, welcome to a new lecture on hydronephrosis. So this is the continuation of old lecture. I would recommend you to watch the old lecture for better understanding. So, as I have said here, hydronephrosis, there is some obstruction in the kidney at any stage, and because of that obstruction, there is dilatation of the kidney, ureters and pelvis. So this hydronephrosis can be divided into many types. In fact, if this is associated with only dilatation of ureter or with only dilatation of the renal pelvis or dilatation of ureter, so that is one type. The second classification is it can be intermittent or persistent hydronephrosis. Okay, let me just show you the classifications because I am not interested in writing them again. So these are the different classifications. Classification 1, hydronephrosis can be unilateral hydronephrosis or bilateral hydronephrosis without renal failure, or bilateral hydronephrosis with renal failure. Classification 2, it can be intermittent hydronephrosis or persistent hydronephrosis. I'll just explain it in a minute, this too. And now the other classification are presence of only hydronephrosis and ureter is normal, or presence of hydronephrosis and also hydroureter. This is one more classification. Presence of only hydronephrosis, here presence of hydronephrosis and also hydroureter. Then classification 4, it is presence of extrarenal hydronephrosis, where the intrarenal papillae and everything is normal, and the other type is presence of intrarenal pelvic hydronephrosis. Presence of extrarenal pelvic hydronephrosis is present in 80%, whereas intrarenal pelvic hydrosis is just present in 20%. So these are the different classifications of hydronephrosis. Now, what does the patient come to us with? So as I have said, in the patients with hydronephrosis, what does the patient come with? If this is the abdomen, the patient first comes with a unilateral pain. If it's unilateral or bilateral, it can be in any way. As I have said, it can be unilateral hydronephrosis or bilateral hydronephrosis. So based on that, the patient will have dull pain in the loin and there is dragging sensation. There is dull pain in the loin and there is also dragging sensation, a sensation that the kidney is falling forward. So there is dull pain with dragging sensation. And there is also mass in the loin, and sometimes you can also find a mass in the loin which is smooth on touch and it is mobile, it is well palatable, okay, and it moves with respiration. Why? Because the kidney is normally attached to the diaphragm above. So because it is attached to a slit of diaphragm above, so as a result, whenever there is respiration, it moves with respiration. Okay, and if you do percussion, on percussion you will see there is dullness, but on one band there is dullness all around, but there is a band of colonic resonance, because the colon will come like this and it has a colonic flexure here and it comes downwards. So as a result, there is a band of colonic resonance in front. Apart from that, everything will be normal. Okay, there can be a band of colonic resonance either here like this or like this. Okay, there is one band of colonic resonance, and there is, as I have said before, there can be one more thing. There can be dysuria or hematuria also, and there is, as I have said before, there can be intermittent hydronephrosis or persistent hydronephrosis, two types. So in intermittent hydronephrosis, the patient will have renal pain. So in intermittent hydronephrosis, the patient will have renal pain, but this renal pain will be acute, and once the swelling in the loin disappears, so first he'll have renal pain, and then he'll have renal pain, and then after some time he passes urine. Once he passes urine, the renal pain decreases and also the swelling in the loin also disappears. So this thing that before passing urine, the patient has renal pain, and once he passes urine, the renal pain decreases and also swelling decreases. This phenomenon is called as Diethel's crisis, which is present in intermittent hydronephrosis. Okay, so this is about Diethel's crisis. And in bilateral cases, and these are the symptoms which you see normally in unilateral cases. If you see in bilateral cases, along with these symptoms, you'll have these symptoms. You'll have mass in the loin, you have renal colic pain, you'll have loin pain. Okay, you'll have all those. Along with that, there are some more symptoms. See, in the bilateral hydronephrosis, the urine cannot come out. It is difficult for the urine to escape out. As a result, if it's severe, if it's completely obstructing the lumen, in such cases there can be anuria. If it's partial obstruction, there can be some features, some symptoms like urinary frequency. The frequency can be increased. Just a minute, I'm not getting. Sometimes the frequency can be increased, or there can be urgency sometimes, or sometimes there can be hesitancy, or there can be poor stream. Okay, so these are the different symptoms which are seen because of lower urinary tract obstruction. All the other symptoms are normal, seen, like mass in the loin, presence of mass in the loin, all features of mass that is moving with respiration, it's mobile, it's palatable, and all those, and there is renal colic pain. All these are normally present, and dragging sensation, all these are present even in these patients. Then how are you going to investigate it? Investigation, we generally do ultrasonography is the best investigation. It is to find out the presence of renal colic. Ultrasonography, it is to find out the hydronephrosis, how much the extent of hydronephrosis. We do ultrasonography. We can do intravenous urography. Once you do intravenous urography, there can be the renal pelvis shape can be determined. Normally it is club shaped. If you see normal IVU, you see the ureter, that is pelvis, extrarenal pelvis has club shaped. Sometimes it can be flat, or sometimes it can be club shaped. See, this is cup shaped. Normally this is cup shaped. It can be flat, or it can be club shaped, or sometimes it can even be broadened. This is based on the severity of hydronephrosis. The renal pelvis shape will change. Okay, extrarenal pelvis shape will change. And then you can also do isotope renography. If you do isotope renography, here if think that we have given isotope technetium 99M, isotope which is labeled with technetium 99M, mostly we give DTPA, which is diethyl triamine pentaacetic acid. Diethyl triamine pentaacetic acid, or which is labeled with technetium 99M. Diethyl triamine pentaacetic acid, this is labeled with technetium 99M. So this isotope is given, and then you will have to see whether this is cleared in the kidney or not. Normally, if you see, it is cleared from the kidney. Okay, but here, because there is obstruction to the kidney, if you see here, it will come, and because it is obstructed, it is accumulated here because it's not going to come out. Okay, so the material which is DTPA, you can see it accumulated in some state. If there is obstruction here, then this will come and this will get accumulated here. So just before the site of the obstruction, you can see accumulation of the substance, which is DTPA technetium 99M. There is one more test called as Whittaker test, which we don't do normally. But what do we do in Whittaker test? In Whittaker test, we will just do a percutaneous puncture of the kidney, and then we will inject the saline. Okay, think that this is the saline. So we have injected the saline. Once we have injected the saline will fill here, right? And normally, first the pressure increases because you are injecting more saline into the pelvis. So the pressure increases, and later, normally if you see, the pressure increases, and then the fluid which is there, this will empty, and as a result the pressure decreases then because of emptying of the fluid. But in hydronephrosis, because there is already a block here, the more the fluid you give, the pressure will increase. Mostly we give 10 ml per minute. At the rate of 10 ml per minute we give. As you slowly give it, the pressure here will increase. But in normal circumstances, there is no obstruction. So there is urinary bladder is a distended structure. As a result, first there will be increase in pressure, but once the fluid will empty, it will empty into the urinary bladder and from there to outside. But here, because of the obstruction, that is not possible. As a result, the fluid which is there, it accumulates here. That is called as Whittaker test. So these are the different clinical features and investigations which we do for hydronephrosis. Thank you guys for watching my lecture. In my next class, I will explain about the treatment of hydronephrosis. Thank you for watching my lecture. Please subscribe the channel for more lectures. Thank you.